Hey everyone, my name is Brian Jaros. I'm coming at you from ACR 2024 here in Washington, D.C. with Room Now, and I'll be telling you about abstract number 1695. So as you probably heard yesterday, a big topic in this convergence is SELECT-GCA. And you may have heard from Dr. Mike Putman's session yesterday with Room Now, but SELECT-GCA is a trial from Dr. Merkel et al. Showing that upadacitinib at 15 milligrams daily was more effective than a placebo 52-week glucocorticoid taper in inducing remission for patients with GCA. Now, the abstract I'll be telling you about today is going to be presented by the same group and was a subgroup analysis of the different types of patients within SELECT-GCA who received upadacitinib versus the placebo arm, and whether there were differences between the two treatment groups when the patients were stratified by different characteristics. And as you can imagine, this is really important for our clinical practice. It'd be really useful for us to know if certain patients, certain GCA patients, would benefit more from upadacitinib initiation compared to other patients where there may not be as favorable or as different of a profile. So many subgroups were used, and in general, upadacitinib at 15 milligrams was more favorable than the glucocorticoid profile, but I'll break down a few of the particular subgroups that I found most interesting and helpful to our clinical practice. So one of the subgroups, they separated the GCA patients by new disease and relapsing disease. And when they looked between both of those subgroups, upadacitinib was more favorable than the placebo arm. And this is really helpful information because oftentimes we think about new disease and relapsing disease as potentially different phenotypes or different severity, but this tells us that upadacitinib looks like it's effective in both of these patient groups. They also looked at subgroup analysis by whether the patients had prior use of an IL-6 inhibitor. And again, regardless of prior use of IL-6 inhibitor or not, numerically, patients with upadacitinib had a more favorable response rate compared to the placebo arm. Though there was a very limited sample size of patients who had received prior IL-6 therapy due to strict inclusion criteria. So a wide confidence interval marred the ability to draw statistically significant conclusions from that subgroup analysis. Another interesting point is that patients with PMR actually did better with upadacitinib or had a more favorable response compared to those without PMR. And this brings up an interesting question in terms of future directions with upadacitinib and JAK inhibitors. Could they be effective in isolated PMR? And I think that's an area of a lot of interest at this conference and a question a lot of groups will be asking after this trial. Other subgroups that they included racial groups, so white versus non-white racial groups, both favored upadacitinib. Smoking status, it looked like former smokers or non-smokers seemed to benefit a little bit more than active smokers. And whether baseline glucocorticoid dose of less than or greater than 30 milligrams influenced response, it seemed like numerically both favored the upadacitinib group, though again with a wider confidence interval in the greater than 30 milligram group not meeting statistical significance. The last subgroup I'll talk about is an important one, which is patients who experienced ischemia-related vision loss. And actually, patients who did not have an occurrence of vision loss seem to have the most favorable response with upadacitinib compared to those who did experience vision loss. The caveat here is that the overall event rate of vision loss was very low in the group, and so again, we're looking at very wide confidence intervals, a lot of variability, which makes it difficult to draw conclusions, but may suggest that those with ischemic vision loss, have a more severe phenotype, which is not surprising, and might require more intensive treatment and monitoring. The authors also used the subgroup analyses to look at their secondary endpoint, which was clinical remission, similar to the primary endpoint, but adding on inflammatory markers. And again, upadacitinib 15 milligrams seemed to really be favored in most of those subgroup analyses, actually with more narrow confidence intervals in a lot of the cases compared to the primary endpoint. So in conclusion, this adds to our information we got from the original SELECT-GCA data yesterday that most patients, a very heterogeneous group of GCA patients, seem to benefit from upadacitinib 15 milligrams daily, which is very reassuring for our use, again, as we see a wide variety of patients in clinical practice. That's all I have for today. Check out Room Now for more information.